Welcome everyone to today's webinar, How to Thrive Amid Uncertainty, Law, Policy, and Growth Strategies for Health System Success in 2024. On behalf of Becker's Healthcare, thank you so much for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you are having trouble with audio or visual, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are always here to help. Thank you all for being here today. I'd like to introduce and turn the floor over to our moderator today, Allison.
Mariah, thank you. Good morning and good afternoon. Appreciate Becker's hosting us for this webinar, and on behalf of Clearway Health, welcome. Thank you for joining. We are so glad you're here. My name is Allison Ariant. I am the Senior Vice President of Client Development and Marketing at Clearway Health, and we're excited to host today's discussion along with our partners that we'll introduce here in just a minute. Clearway Health is a company who partners with hospitals and health systems across the U.S. We help support them in their pharmacy and their specialty pharmacy journey by bringing experience and expertise that's grown out of another hospital and health system, Boston Medical Center Health System in Boston, Massachusetts. And so we've taken that expertise and lived experience and now share that to create incredible specialty pharmacy programs that support providers, clinicians, and the communities of patients that they serve. Today, we are honored to have friends in the industry to join this discussion. We have Laurice Rutledge-Lambert. Laurice is founding partner at Health Law Strategists. We have Beth Feldpush, who is Senior Vice President of Policy and Advocacy from America's Essential Hospitals. And we have Nicole Fauché, who is President of Clearway Health. And without further ado, we're going to jump in and get started on today's topic and discussion. So to start the discussion, when we're talking about health policy, advocacy, and everything that exists in uncertain times across healthcare, a really good place to start and to ground us is, what is your perspective on current policies and market influences in healthcare? And Laurice, I'd love to come to you to get started to share some of your thoughts.
Thank you, Allison, and thanks, Becker's team. I appreciate the opportunity to be here today. So yeah, jumping right in on this point, I would say the biggest thing that I'm seeing is really this consumerism of healthcare that we're seeing today, the shift away from facility level care to care in the home, on-demand care, care in a comfortable setting. I'm even seeing as much as asynchronous text communication to help facilitate care in certain settings. We're also seeing a lot of, I think, over the past couple of years, the big box chains, the big box stores moving into healthcare. We saw CVS last year being very acquisitive with its acquisition of Oak Street Health as well as Signify. We've seen over the past few years the continued relationship between Walgreens and VillageMD growing via expansion and M&A and investment in that relationship. There were discussions last fall over the alignment potentially between Walmart and ChenMed. As we've also started to see a lot of traditional technology and tech-enabled services companies moving into healthcare. So Instacart, for example, started Instacart Health about a year and a half ago, and in January announced a partnership with HHS to use food as medicine and to help figure out how we can improve outcomes using food. This is a traditional technology company that was, helping deliver groceries to your door, moving very much into the healthcare space. We also know about 5 years ago, Amazon acquired PillPack to have it start Amazon Pharmacy, and then acquired One Medical about a year ago. So we're just seeing a lot, right? I mean, when I started my career in healthcare 15 plus years ago, none of this was even contemplated. The other thing I think that's really interesting, I think we're seeing a lot of is, incubators, venture capital, and then founder-led, owned, and bootstrapped companies. There's really kind of no stopping this influence on healthcare and of technology on healthcare. And so bringing it back to kind of, I think, why we're here today in the hospital and health system market and what are the considerations there, I think we have to all recognize that it is not as being a nonprofit system in certain situations, in particular, is not the same as keeping up with a publicly traded technology company as, you know, or publicly traded kind of healthcare entity, nor is it the same as being a very early stage, very nimble, 10-person tech-enabled services startup company. We're seeing hospitals and health systems starting up venture arms with different constituents starting up venture arms to try to compete and play in this space. But there's different constituents, different goals, and different priorities. You know, hospitals, as I think many of the people on the line can appreciate, have to balance innovation with cost. Many, I think, of the people on the line today are with nonprofit systems. And as we know, hospitals have different priorities, strategic goals, risk profiles, stakeholders, than publicly traded technology companies, as well as earlier stage companies coming out of incubators or that are venture capital backed. And I think top of mind with everybody with the recent news from Change Healthcare and the data, some of the data implications that are out there as a result of that, is that data security often presents a really strong barrier to entry for hospitals. I think it's always top of mind. It is so crippling to a hospital to have to deal with a data breach. Hospitals are a huge target for that. And so it's just not as easy for hospitals and health systems to go head to head with certain of the other competitors. So that consumerism and shift, I think, is really something bright and shining on the industry now. But how do we all play together in this kind of evolving landscape? And so from there, Allison, I'll kick it back to you.
Yeah. Thank you for that. And you said something, there's no stopping the influence of tech and healthcare. And I think with that comes, there's no stopping the constant change that comes with that and the force that hospitals and health systems are taking to adapt and to react to that. And so, Larice, appreciate those comments. And Beth, I'd like to come to you next to talk a little bit about how we navigate this constant influence and force for change as you think about the boundaries that are created for hospitals and health systems and even the ways they're having to protect and defend the markets that they serve.
Sure. Thank you, Allison. And on behalf of our member hospitals at America's Essential Hospitals, I'm delighted to join you today. Yes, I think there's several kind of unique things sort of in the atmosphere these days that really touch on the boundaries of where hospitals are operating. We have seen sort of expectation creep happen over the last 5, 10, even 15 years, with an expectation that as often the dominant, largest healthcare players in their markets, there's an expectation for hospitals to now go beyond just delivering care within the four walls of their building. And we've seen that shift over time. First, it was sort of the migration of services from the inpatient to the outpatient setting. Then there's been more and more of sort of an unfunded mandate and expectation that hospitals look out for population health, community health, making sure that we're keeping people well in the community before they even seek services at one of our institutions. And I would say in the last 5 years, we've seen further expectations that hospitals take a larger role in mitigating social determinants of health in their communities, whether it's homelessness or food insecurity, combating structural racism, climate mitigation. And I think, all of these goals are certainly worthwhile and worthy of hospitals' time and attention, given their roles in the communities. But there must be a challenge for hospitals in trying to navigate and determine where do your service delivery end? What are, you get reimbursed and paid for services that you deliver to patients. Where does that end and meet up against these community expectations and these sort of unfunded mandates? So I think it's challenging for hospitals to know how far out they should be reaching into their communities, knowing they can't solve all of society's problems, but certainly need to play a role in that. And so I think those expectations are real and challenging for hospitals. The other thing that I'll note that we've seen over the last year or so is sort of this public image backlash against hospitals in the wake of the pandemic. So wasn't that long ago that we saw lots of hospital hero signs, people standing on the sidewalk in the street corner. But we've largely seen that dissipate in the last year or so. I think some of these challenges have been funded, quite frankly, by a small subset of wealthy or powerful individuals or organizations that seem to want to go after hospitals and their prices and their place in the healthcare ecosystem. But I think more than that, when you're facing a workforce that continues to experience burnout, we've seen rising violence against healthcare workers, unfortunately, and not only in quantity, but unfortunately, the types of injuries that our workforce is sustaining. Having to do your job and provide that care on the back end of a pandemic when you're overworked and experiencing burnout, and now you've got this public influence saying your prices are too high and you're bad actors, I think that's incredibly challenging. And how do hospitals, again, continue to engage with their communities or compete against some of the organizations that Laurice mentioned while they're kind of dealing with these challenging public image issues.
Beth, thank you for that. And in the face of fighting these challenges and overcoming these obstacles, this question that you pose, which is how far do hospitals and health systems reach, and how do they balance this expectation creep that comes with doing more with less in a constantly pressured environment? And so, Nicole, when you think about how these hospitals and health systems are protecting and defending their market share and how they choose to innovate and strategize and partner, what are some of the things that you think about?
Thank you, Allison, and thank you, Laurice and Beth and Becker's. Really excited about our conversations today. I think that idea of protecting the hospitals and health systems marketplace suggests that these concepts are really important in a competitive environment. But the reality is some of the things we're talking about impact urban competitive areas as well as rural health. And I think one of the things healthcare continues, if I look at this more from a market influence lens, is that healthcare constantly learns by the advances in other parts, other industries, right? If you look at the advancement of kiosks and check-ins, that probably branches off some of the airline experiences we've had over the years and what have you. And so, one of the things that I think we, from our standpoint, start to look at in the market is how can we help the hospitals and health systems continue to advance, but not necessarily be the person in the front talking about that. Because I think ultimately patients and people might be intrigued by the Amazon's entrance into healthcare or Walmart, but the reality is they really rely on their hospitals and their doctors as their caregivers. And so when you think about, do I think about Amazon when I'm sick? No, I think about my local hospital or I think about my doctor's office. And so there's an element to this, which is how do hospitals and health systems advance their ability to deliver care in a way that suits the expectations of the patient and the community and leverages partners in a way that are a bit invisible to the patient themselves. And I think that's really key. It's probably been almost a year and a half ago, which seems a little bit mind-boggling to me that was this long ago. I remember making a post that the Best Buy partnership with the Geisinger was a bit of a head scratcher to me, because I was like, I don't quite get it, but maybe there's something here I don't understand. And I think that that's true, which is that Best Buy, if you think about what they provide, none of us would think about it related to healthcare, but the reality is Best Buy isn't opening a space like some of these other examples I've been given today. They're looking at how to support patients to receive care more at home and do so through hospitals in a sort of invisible kind of way. I think it's a really unique way to look at it. And something that I think we'll see more and more of, which is how do people support hospitals, provider practices and their delivery? And how do we do so in a way that helps bring the consumer, to go back to some of what Laurice was talking about, the consumer part of the way healthcare works, because all of us, I think, would admit that we'd like for all of that to be a little bit easier. How do we schedule? How do we get to the doctor's office? How do we make sure things are on time? How do we get the results that we need and do so in a way that's as frictionless as possible, which I think is one of the key areas that we tend to focus on. But so I think from a market influence place, we just really need to learn from the other industries and then bring those industry leaders in. If Amazon can help us in things like supply chain and infrastructure, amazing, but maybe not necessarily in the actual healthcare delivery space itself.
Good, Nicole, thank you for that. And coincidentally, you landed with some thoughts around navigating things and bringing in expertise for things like supply chain, which I think is a really good jumping off point to our next concept in question, which is what are successful ways that hospitals and health systems have navigated challenges amid inflation and rising healthcare costs? Certainly, labor costs are top of mind. supply costs top of mind, even looking at how we rely on some of those lead from the front technologies that Nicole talked about. And so, Beth, I'd like to start with you to share a bit about some of your experience with your partner hospitals and how they've navigated these challenges.
Yes, I think the first thing is, we need to acknowledge it that these cost challenges are not going to go away anytime soon. When we look at government payment rates, which a lot of our members are dependent upon Medicare and Medicaid payments for at least a substantial portion of their reimbursement, those reimbursement rates are nowhere near keeping up to the inflation that hospitals are seeing in their labor costs or supply costs. And I don't think they're going to in the next few years. So where we've seen hospitals be more successful is really trying to keep a dual focus on looking at their workforce challenges and the cost pressures there for both what can they do today to start to drive costs down and how can they invest in the pipeline for tomorrow. So we've seen a lot of folks pay a lot of attention to recruitment and retention bonuses in their own teams. We've seen overtime hours increasing, but at the same time, a dependence on travelers or contracted healthcare workforce has gone down. So, we've seen, again, kind of short-term increases perhaps in folks' labor costs, but trying to decrease that reliance on consultants and contracted employees. We've also seen hospitals really try to be very entrepreneurial and creative in how they can increase tomorrow's pipeline. So we've had members that have partnered with community colleges or even high schools to try to increase not only clinical workforce, but others as well. We have seen hospitals actually pay some of their staff while their teams are getting further education. They are paying them to not only get educated, and covering the costs of their training, but also paying them a salary while they are in school, with the promise that those folks will work for 2, 3, 5 years at the hospital afterwards. So I think that dual focus of what can we do now to drive down our labor costs versus or paired with investing in the future is something that we've seen that has worked for some hospitals. But acknowledging those labor costs are continuing. Another thing that we've really seen folks do is look to how can technology help them, but trying to start with sort of the low-hanging fruit on AI. I think a lot of our hospitals are apprehensive about jumping into using AI wholesale, but I think that there are some low-hanging fruit around some of the administrative functions that can be helpful in increasing hospitals' efficiency. So areas around looking at what technologies are already built into your electronic health records in terms of whole language processing to help your clinicians capture their notes more easily, looking at how you can use AI for prior authorizations or filing claims. There are some, pretty more simple tasks that hospitals may have the capability already to do that they can leverage without saying, we're jumping in wholesale to implementing AI for every clinical function everywhere. But look at what you maybe have at your disposal already. And we've seen folks be successful with that.
That's great experiences, and appreciate the perspectives from the member hospitals that America's Essential Hospitals supports. So thank you, Beth, for that. Laurice, I want to come to you next, especially from the lens of work that you're doing as you're navigating these partnerships, often from a legal perspective with partners. Nicole talked about the concept of invisible partnerships. You talked earlier about the relevance of hospitals and health systems, keeping that relevance front of mind. So when you think about strategic partnerships, how are those helping hospitals and health systems navigate this do more with less environment?
Absolutely. Thanks, Allison. And, Beth, I was going to hit AI last on my list, but I'm going to jump off of kind of where you landed. So I see a lot in the tech-enabled services space. It's actually my favorite area to practice in because it blends the world of providers with the world of technology. And So I guess taking it in a little bit of reverse order than what I was originally going to do, Beth was talking about AI, and to Beth's point, there's a big difference between the AI regulated tools by the FDA that are considered tools that are, really providing or guiding on care, to tools that are helping, drive revenue or mitigate cost cutting. So again, I think the takeaway I would say from AI is, don't be afraid of it. But some of the challenges and things that I've seen, and I've seen hospitals trying to do to protect themselves is, how do you limit the use of the AI of your data? How do you protect your PHI? How do you make sure that someone's not going to take your PHI and resell your PHI? And I think, good legal counsel can help you navigate that. But ultimately, your data will help the AI get better. And in many cases, not just for you, but for others as well. But so long as no one is using that data in a way that is contrary to the legal, state and federal legal schemes, is that really necessarily the worst thing, right? If it's all helping everything move, helping dollars to the bottom line and/or advancing patient care. So I think we're seeing, to Beth's point, AI to predict missed appointments, identify things like sepsis risk and detect stroke, malnutrition, help make bedside diagnosis as we push the envelope a little bit towards the care side, as well as things like freeing up OR space and identifying ways to drive revenue to the bottom line of hospitals. So that's one area where I'm seeing it. I'd say going back a decade, urgent care alignments, right? I mean, in the Atlanta market where I sit, there's a very large system here that has a co-branded partnership with a very well-known urgent care player. And I went there on Saturday with my daughter. I mean, it is easy, it is quick, it is convenient. My pediatrician wasn't open, and it is a direct entry point into their system. It is integrated with their medical records. They have my information on file. So it is easy. Talking about consumerism, it is easy. They had a table with coloring book. It made things easier. And so I'd say that's an angle I think I've seen in a lot of markets of those the urgent care alignments. Remote patient monitoring, I'm seeing a lot of, and we're going to talk a little bit more about this as we get to value-based care. But I think the tools, some of these remote patient monitoring, chronic care management, we're going to get to that moving away from fee-for-service to value-based. These are areas that CMS is reimbursing for. The dollars, are meaningful, especially on the physician clinic side of the world. And so I'm seeing a lot in RPM and CCM, and I'm seeing it both ways, white labeled or co-branded, typically under physician supervision of the physicians employed or contracted by the hospital. And then, of course, specialty pharmacy. I mean, specialty pharmacy has not only high quality outcomes, it allows hospitals to compete in this ever-changing 340B landscape that we're going to get to later in the presentation. And it has positive outcomes on patients. It utilizes technology in the right way, and it also can drive revenue for health systems in the right way. So I'm seeing a lot of strategic partnerships and alignments. I spend a lot of my time here, and I think there are ways to navigate this as a hospital and health system to mitigate risk to you, but to also keep you kind of there on the forefront of where things are changing and evolving.
Lorice, thanks. And finding some of those perfect storm trifecta scenarios where it creates improved clinical and patient outcomes, improved operational performance, and strengthened financial standing of organizations are, I think, very, very hard to find. And so the things that you're talking about are really important. You talked about driving revenue back to the bottom line, creating an integrated system or solution or service, and then ultimately making it convenient and easy, both for the clinical care teams and the patients, as well as the organization as a whole. So with that, Nicole, I'll come to you to talk a bit about what some of these strategies have been for hospitals and health systems that you've partnered with and that Clearway Health supports in specialty pharmacy services.
Yeah, I think the pharmacy as a service line for health systems for years now has been, I think, growing. It was, again, a little bit of an underrepresented group related to revenue opportunities for health systems that has become more and more evident. And it's not just the financial opportunity, which you mentioned, but over the last few years, as more and more hospitals are owning their own outpatient pharmacy, specifically a specialty pharmacy program, they are able to, one, drive a healthier financial performance, but they also drive a tighter patient connection, and they also tie to improved provider access and their satisfaction, because when you're looking at being able to totally manage the patient from the point of diagnosis through treatment, in this case, medication dispensing, you really kind of be able to look at this concept of like working at the top of the license. We have a customer that we have today who on average would probably be spending somewhere in the neighborhood of 1,400 to 1,600 hours a month on prior authorizations for specialty medications. By and large, if we all look inside of each health system, you will find that there are a lot of individuals who are performing that task who would be better off spending time with patients or seeing people in clinics, improving accessibility. And instead, they're doing this very administrative function. By doing so, it really changes the whole dynamic within the system, patient experience, financial performance, and even in overall operational excellence. And so the specialty pharmacy program, in partnership with leveraging 340B strategies, really provides an opportunity to navigate some of the cost challenges, helps alleviate some of the overall friction that I've mentioned a little bit earlier in this call in terms of how do we make it as easy for the patients and the providers as possible. And lastly, it does help you control costs. By the nature of 340B, helps provide a cost containment measure and provides ways to help fund very, very important services within each of the health systems that typically might be under-resourced related to financial or people. So I think that if you are an organization and you understand your patient population from a standpoint of specialty mix and provider prescribing habits, I would highly recommend taking a look at pharmacy as a service line to help navigate some of these challenges.
Thank you for that. And when we think about this concept of reducing friction, you talked about cost containment, cost management, as well as revenue and margin generators. I think it tees us up well for our next topic, which looks to what Laurice previewed just a few minutes ago. How can folks on the call today successfully navigate changes in the changing reimbursement landscape? So as we move, from fee for service and look at some of the value-based care types of initiatives, Laurice would like to start with you to hear your perspective on that.
Thanks, Allison. Yeah, I mean, I think it's been, I think a topic of every conference you go to, everybody you talk to, from the technology side to the provider side, is how do we get to value-based care? What is value-based care? And I think there's not one thing, right? Value-based care hasn't really been fully defined yet. I mean, Medicare Advantage is in theory an example of value-based care. That whole program is meant to help manage conditions and mitigate costs. But I think ultimately, the way I view it is the goal of the healthcare system, CMS, CMMI, to move away from what I would consider truly sick care to well care, right? And the hard thing about that, I was talking with somebody about this yesterday, and a new model they want to do in a space that's been largely untouched from a value-based perspective, is it's not only a change in practice patterns of the providers, but it requires accountability and responsibility of your own healthcare by the consumer, by the patient. And if everyone's not aligned, it's really, value-based care is hard. And so we're seeing a lot of innovation there on the CMS front. CMS is pushing for this, and in part they're pushing for it by continuing to drive down fee-for-service rates. So it's becoming fairly unsustainable. And I was talking to somebody about the reimbursement rate, I think of maybe an outpatient, it was either a total knee or a hip replacement. And the new reimbursement rate structure for the professional side of that is almost about $14 an hour. These are orthopedic surgeons with significant training. And so I think CMS is sending a message, and the commercials follow CMS, and Medicaid, as we all know, is way below where Medicare and the commercials come out. And so they're pushing us in a direction, but there's it's so hard to get your hands all around it. I think certain markets are easier than others, right? I mean, Kaiser's had tremendous success in the California market. I mean, because risk-based care was adopted very early out west. So I think it's going to be really interesting to see what happens. As we know, Kaiser has announced its Risant initiative and the potential acquisition of Geisinger and the enfoldment into the system there. So it'll be really interesting to see if what kind of impact that has. But robust value-based care, the biggest challenge is data. And I think no one has fully solved the interoperability problems, right? We still have multiple different record systems. We still have multiple physicians in the community that their systems don't talk to the hospitals. And even though Epic has done a great job of it, everybody's not on Epic. And so data is kind of king here, and we haven't solved the data crisis. And I could go on a tangent about who owns the data. Is it the patient? I mean, I think a lot of people would say the patient owns the data, but that's a state by state issue. And as I kind of alluded to, it requires alignments from not just your hospitals, but your primary care docs, your specialists, post-acute providers, as well as a lot of these third parties that we're talking about that are coming in and helping support the providers in a tech-enabled way or in other offerings. So I would say navigating change is going to be continuing to think about how to move in that way, even if it's a small way. I'm not ready to convert off my fee for service contracts as a hospital level, but maybe I can do some things in my freestanding clinics, or maybe I can form an ACO, or maybe I can set up a strategic primary care network. There are ways to kind of enter that space and test the water. I think the other thing we've been seeing for years, really ever since 2015, right, when we had the Balanced Budget Act and then kind of clamping down on the use of provider-based status by hospitals, is hospitals now competing, though, in the truly freestanding market, if you will. So we've seen surgery centers in the outpatient space and the freestanding space for many years. Most of those are owned by physicians, but you're seeing some hospital joint ventures, or not some, many hospital joint ventures in that space. Imaging, right? When I first started practicing, imaging in the hospital was where it was at. Let's get all the imaging centers we can, and there's great upside to charging hospital-based rates. Again, the government caught on to that, and that has largely been clamped down on. And so there's not as much of that happening. Infusion's a new one. There's been some commercial payers pushing on not wanting to reimburse for infusion in the hospital-based setting. So there are, companies out there working to bring infusion to hospitals so that they can compete in a freestanding manner as well. And then, like we've talked about, specialty pharmacy as a managed service, or just pharmacy as a managed service as well. And so the last point I have on this is we're seeing hospital at home, right? So that whole truly taking the most acute opportunity for care and bringing it to the patient's home. Obviously, there is very limited situations where this works, but I like this example because it also loops in that remote monitoring, right? You can't do hospital home without remote patient monitoring, without equipment, without technology. And so that's a great example of how hospitals are using technology to their advantage and providing patients care in the setting that is most beneficial and most cost effective for the patient. So those are some of the things I'm seeing. It is not easy because I don't think there's a perfect transition from the change in fee for service to value-based care. And the last point I'll say on this is, I mentioned CHEDMED earlier. I had done some reading about that organization. And one of the things they said about value-based, because what they do is value-based care, is it's such a shift of providers too. And they train people for months before they kind of launch them into their system. And so it's just so challenging because providers caught between fee-for-service and value-based doesn't really work because it is a totally different way to treat the patient. And so until we can get to a place where there's a way to evolve in that doesn't get you stuck in the middle, which I don't know there's a solution for that, it's a challenging problem, but I do think that's where we're trending.
Thank you for that. Beth, I'll come to you next. A lot of what Larice talked about is really the structural, organizational strategies for hospitals and health systems. One of the things you talk a lot about is really looking at the populations that these hospitals and health systems serve. And so would like to hear your perspective on strategies for these changing models and how organizations can look at their communities for ways to look for strategies.
Sure, Allison. So, I agree with Larice that this is definitely going to be a bumpy journey and, not a quick one. I think we're going to be living for quite some time with sort of one foot in the fee-for-service world and one foot in the value-based care world, and sort of trying to kind of keep our balance between the dock and the boat there. To your point, Allison, of looking at your patient populations, I think the first thing I would say to a hospital is you're only going to be successful at providing new care models if you focus on the patients that you have and not maybe necessarily the patients you want or the patients that you don't have. So if you have a lot of Medicaid patients, maybe a Medicaid ACO is where you should look first and not a Medicare ACO, vice versa. If you have a lot of Medicare patients, look there. So don't do something if it doesn't feel like it's a natural fit for the community that you're serving. I think the other thing is we look forward while we kind of continue to live in what is oftentimes a fee-for-service world, but sort of see more value-based care or global payments on the horizon, is to start to maybe look at your care delivery with a value-based mindset, even if you're still getting dollars in the door for fee-for-service. So, for example, I know one of the things we hear a lot from our members right now that's a challenge is their throughput and discharges into the post-acute setting. We think hospitals have workforce challenges these days. The post-acute setting has been even more devastated. And so many of our members are really, really having challenges in being able to discharge patients because they don't have beds in post-acute setting for them. And if you can't discharge patients, you can't move people up from the emergency department into beds. So we've had some members try to do some creative things in the post-acute setting, whether that's where partnering. There have been a couple Medicaid programs where there have been some Medicaid financing arrangements established by the state and approved by CMS to allow for sort of increased reimbursement to post-acute care settings that will admit and take care of kind of maybe harder patients with more social challenges and Medicaid payments. So, again, even if you're really still getting reimbursed by fee for service, think of what you can do kind of more across the care continuum. The other opportunity I want to make sure I point out to folks is that this administration is really focused on health equity and social determinants. And we've seen them make some incremental changes in the fee-for-service Medicare space that sort of get at those larger global challenges. So a big example of this is last year, CMS finalized the use of Z codes, which capture social determinants of health. So CMS finalized that now if you code a patient for homelessness using a Z code on the claim, that will increase your payment for that inpatient DRG because that homelessness code will now count as a comorbidity or a complication and increase your DRG payment. So it's still a DRG, it's still a fee-for-service payment, but when you start to look more at these kind of community level factors, that's the type of thing that could maybe help you navigate that change, still getting paid on fee-for-service, but taking those more holistic viewpoints in mind.
Thanks for that, Beth. And that's a perfect example of the constant and continuous change and being mindful of that. And we'll talk in a bit about some resources that will be helpful for folks that have joined that they can access and looking for ways to help with some of those strategies. Given the constant landscape, one of the most talked about constantly changing parts of our landscape is surrounding the 340B program. And so want to talk to this team a bit about some of the implications and opportunities that have come with a lot of the recent changes surrounding the 340B specialty drug program, with recent rulings from the Genesis case, the Inflation Reduction Act, even Supreme Court and state by state type of decisions that are happening. Want to talk about the implications and opportunities. And Nicole, let's start with you.
Thank you. In this space, there's really 3 or 4 things that we tend to spend a lot of time thinking about. And while there are implications for each of them, I believe they create a lot of opportunities for the covered entities within the 340B program. The 4 items that really come to mind are, 1, the Genesis ruling that I'm sure we'll spend some time talking about here on the call. But this concept of, patient definitions and the ability to leverage and understand the reach of the 340B program within the settings of the patient encounters. I think that will continue to be challenged and discussed, and we'll see some changes over time there. The other is, I think, very promising is some of the state actions related to protecting 340B. I think there are now, if I have the number right, 11 states that have either passed or have bills that are under review to protect 340B implications to manufacturers, as well as trying to protect any predatory actions by PBMs or payers and for 340B covered entities. I think that's very promising. I think we'll see more of that and encourage individuals in those states to support such bills. Then we have the Inflation Reduction Act, which I think it's really fascinating as you dive into it related to the pharmacy space, because it kind of starts talking about some of this risk-based that we just finished in the reimbursement side, which is as you're understanding your patient populations and the implications of the Medicare, Part D, as well as some of the commercial payer implications, really having your hands around managing the population, utilization management, understanding your formularies is really going to be an opportunity for systems in the event that you can leverage the data, as many of us have said on the call today. And I think while I didn't expect interoperability to come up on this call, I guess we can't get away from it in healthcare. So thanks, Laurice, for that. I think understanding all the various places and how prescribers are behaving really are impactful here. The last is, I think the Senate inquiry recently, earlier this year, looking at, how are contract pharmacies behaving? How are organizations using their 340B dollars? There's a lot of interest in understanding, like, really how are patients and communities benefiting in the hospitals, leveraging this accessibility to improve costs for medications and the dispensing. I think all this creates an opportunity. It is challenging because there's seemingly an ever-changing amount of information coming, and how do you respond and understand? And I think the biggest concern all entities tend to have is, how can I keep doing this and be compliant so that my program is not at risk? And that is, I think, an important question. I think it's also why it's important to have partners and team members that are constantly helping sort of kind of dive through this data with you, so that decisions and actions are really in alignment with the spirit of the program. But I don't believe that these will slow down. I think we'll see more and more of these, but I think you have a lot, there are organizations like American Essential Hospitals, ours and others, who are looking to ensure that we support this program and have its longevity over time.
Good. Nicole, thank you. Laurice, and anything that brings challenges, I think, also brings opportunities. And so Nicole talked a bit about the compliant way to navigate and uncover opportunities in a changing landscape. Talk to us a little bit about your perspective on those opportunities for the 340B program.
Yeah, I mean, I think it has been interesting. I mean, even 2 years ago, we're starting to feel like, is the 340B program at risk? What are the headwinds vis-a-vis 340B? What does the Inflation Reduction Act mean for, managed pharmacy programs? Is that going to put these programs at risk? And I think, we've actually seen a little bit of a shift, right? I mean, I think Genesis is a really interesting decision. It is limited to that situation. I'll just give a quick high level of facts. I mean, it involved a federally qualified health center and their definition of how they were using the definition of patient. And I think one thing to note, and bring it back to compliance, and one of the biggest things, if I'm representing a hospital, right, is at the end of the day, you can have a managed partner, but it's at the end of the day, you're the one billing for the services, right? And so I think the right partner is going to understand that risk brings to you as a hospital and a health system, and the ultimate direction and control you need. But a good strategic partner is going to work with you and make sure everything is above board, knowing that ultimately you are driving the compliant approach for how to navigate, whether it be 340B or billing generally. But in Genesis, it involved a federally qualified health center who, those facilities are eligible for 340B participation. And they had their definition. And the challenge with HRSA and 340B has been that HRSA has never been given kind of the, if you will, the respect it needs to promulgate the necessary rules to actually run the program. So we've got guidance from the 90s about what a patient is. Then they tried to come out in the mid 2000s and then all the way up through 2015 to provide a little bit more information on how you define a patient. And then they were trying to use some of their previous guidance. And so then they were holding Genesis to arguably a higher standard than what the original patient definition was. And ultimately that was found to be improper, saying that they really couldn't hold, they didn't have that HRSA didn't have the ability to promulgate those rules. And so therefore they couldn't hold Genesis to this higher, more restrictive patient definition standard. The hard thing about Genesis is they didn't actually come out and say what the standard should be. And so it kind of takes you back. They actually point you, instead of looking at the 96 guidance that we have from the Federal Register, they actually point you back to the statute, which is really interesting because the statute doesn't actually have a great definition. It is much broader. So what I take from Genesis is the ability to be a little bit risk forward about how you define a patient, as long as it is arguably a patient that you are providing services to. Now, I would still recommend as a lawyer, and that's my job, is to kind of find the medium between The gray and maybe where the line is I'd still recommend you follow the 1996 guidance. But Genesis is a really interesting case now, very limited to that. They've made it clear that that holding is specific to that federally qualified health center, but it is good precedent to have. The problem with it, of course, as any litigation is, it's precedent so long as you want to fight it. So that I think presents challenges and also brings back why we need to be working as third-party outsourced vendors compliantly with hospitals and our system partners to find kind of that happy medium. But interestingly enough, I mean, a couple weeks ago, we had the Sustain 340B Act request for information that has been published, and comments are due April 1, published by about 6 senators. And really interesting. They actually hit on the patient definition concept. They address the ongoing litigation in the contract pharmacy space. It's really looking to do that, sustain 340B, but also give it some more teeth, allow for transparency, provide ways for there to be appropriate corrective action measures and fines for people that are not following the rules, both on the manufacturer as well as the participant side. So there's a lot going on there. And I think I personally feel there's been a shift from where we were a couple of years ago, which was, the program's in jeopardy, to no, we need the program, especially now that hospitals in particular, especially in a lot of areas of the country, are struggling because of this changing reimbursement, and we haven't gotten to value-based care. I mean, you can't pull the rug completely out from underneath hospitals. I mean, that just will not work. And so I think we're seeing some good positive tailwinds there, but we're still a little bit of a ways away from knowing how it's going to all shake out. The other thing I would say that I want to flag as interesting related to all this is what's going on specifically with Chevron. We've got this 40-year-old doctrine where the courts have had to be very, very deferential to agencies, both at the state and the federal level, to basically take what the statute says and give it discretion, right? And if you think about Genesis, that's really what we were seeing. We were seeing a lot of deference to the statute. And so overturning Chevron, depending on how you look at it, could be awesome or it could be terrible. If you're the federal government, I mean, it could be very traumatic, right? Because now all of a sudden, things like what we saw with the fight over the 340B cuts a couple years ago with the American Hospital Association versus Azar. In that case, I mean, think about that. There was so much that was going on in that decision. So all that to be said, we are seeing a lot in the legal world right now, in the courts, in Congress about this particular topic. I think we're going to see a lot more. And I think Chevron in particular is going to cut across. It's not just going to be in 340B. It's going to come across all different, decisions and whatnot that have come out, and give providers with deep pockets the ability to challenge things they hadn't challenged before. So I think there's a lot going on right now. And I think there, with anything like that, with any shakeup, there comes opportunity.
And with opportunity also comes some good news. And so Beth, I want to come to you on this one. So there's good news amidst the challenges. Tell us a little bit more about that.
Yeah, thank you, Allison. I think it's, always great to highlight good news when we can in the healthcare policy, regulatory, payment world. It seems like there's a lot more bad news than good news. But we were thrilled that hospitals have recently received their repayments from the lawsuit that Laurice mentioned, where the National Associations sued HHS over the cuts to Medicare outpatient payments. It started back in 2018. So it was a long journey, but we prevailed, and hospitals should have received in January lump sum repayments for those illegal Medicare cuts from 2018 through 2022. So again, you should have gotten those already. If you haven't, please reach out to your state or national hospital associations. But yeah, always nice to be able to highlight good news when we have it. Thank you, Allison.
Absolutely. Yeah. And thank you too, not just for the expertise to this group, but for the advocacy, Beth, especially with America's Essential Hospitals and the ways that you're advocating for your member hospitals and for the things that matter. So appreciate that greatly. Let's turn next and talk a little bit about a few concepts that have come up throughout this morning. Constant challenges, constant opportunities, and the need for speed and scale are at an all-time importance. And so when hospitals and health systems are deciding how to navigate the landscape, there is a choice whether to build, buy, or partner. And so this group, I think, has unique perspectives in each of your spaces on these topics. And Laurice, we're going to come to you first to talk about that.
Absolutely. Thanks, Allison. I think it is a hard decision. I think there's often well, I can build it myself, or why don't I just go acquire this company now? M&A activity is expensive, and some entities have the pockets for that, and others do not. And so oftentimes I think some convincing individuals to partner can be challenging. But one thing that has been told to me, and that I think comes up time and time again, is it's often better to have a percentage of something than 100% of nothing, right? And I think can be challenging to stand something up from the ground up with limited staffing, limited budgets. It's also hard to get traction when the people that are trying to stand up a new service line have competing demands on their time. So I am seeing there's still a lot of M&A activity happening in healthcare, but I do think there has been I have seen boomerang back to entities that say they're going to build it, to partnering. And I think I'm seeing a lot more traction across some of the areas I mentioned earlier, with partnering with really great third-party vendors to, bring something to the market, kind of in that invisible partnership way that Nicole mentioned.
Yeah, that's great. And Beth, for you, where you have experience with member hospitals that are choosing to partner while also focusing on access and equitable care, tell us a little bit about what some of those strategies have looked like.
I think the number one question that our members tend to ask themselves when they're looking at these challenges is, does it make sense to have our brand on it, whatever the it is that we're talking about? And if it's something, say, like an ACO, or maybe an insurance product, or a new outpatient center, or specialty pharmacy, if you think that it is so central to your mission from this kind of patient service or community connection perspective, then I think it makes sense to either build it yourself, you clearly have that expertise already, or partner with someone, but make sure that you are sort of the public facing partner. So again, a lot of times that's the question our hospitals will first ask themselves is, do we want to have our name on this? Is that important in this decision? And then I think a lot of it comes down to the finances. Are there others in the field that have been able to create some of these services, or have these widgets out there that they've created economies around it that you as one provider can't possibly replicate as well? We've seen some excitement around a new interpretation service that links patients through a Zoom chat with any interpreter is speaking hundreds of languages kind of across the country. And having that video interface is still kind of a pretty personal touch. So, I think, again, it's sort of like, do you want to be the public face on this? And do you have those resources for that to make sense? By all means, and build it. But you might be better off buying or partnering if you answer no to any of those first two questions.
That's great perspective. And Nicole, I want to come to you next on this one, because this concept of invisible partnerships, and then the assessment that Beth walked us through of when and where it makes sense to build or buy or partner. The reality is all of those things can also coexist in a sequential order, where you start in one model and eventually phase to another. And so talk to us a little bit about approach to partnership, especially in the specialty pharmacy space with hospitals and health systems that Clearway Health supports.
Yeah, it was interesting. I was kind of where my mind was going as well as Beth was talking. This idea of build, buy, or partner actually has a few nuances. There's literally the build, meaning you don't have a pharmacy and you don't have access to this, and you're starting from a very de novo place, and you're quite literally building. And then there's a time when you maybe have the bricks and mortar, you have it, but you don't necessarily have the patient dispensing. You're not actually built up the actual program itself. And then buying, in this case, may or may not be actual pharmacy buying, but let's say a consulting service, one that provides you guidance, but not actual execution strength in terms of really building out the program itself, and lastly, partnering. I think in every instance in what we represent, the healthcare systems brand is most important, and that it absolutely should be built, bought, or partnered underneath that logo, in the sense that it is their patients, it is their community, and this is a service that they provide. So this concept of sort of an invisible partner, I think, is really important at the end of the day for so many different reasons. But the other part to it outside, I mean, Laurisa's point around your teams already have a lot on their plate. The idea that someone could on the corner of their desk build something meaningful is very, very difficult and unlikely, no matter how strong some team members might be. The other part to it is even if they are, the reality is some of these programs require that there's a level of change management or disruption to people's practices, meaning providers' behaviors, sometimes patient behaviors. And those things really require that there's a sort of centralized approach to educating, engaging with all these different constituents to really make your program as strong as possible, strong in the sense of the experience, which is critical, as well as strong in the sense of its actual performance. And so I think you have to leverage a number of things, like how well do you really know the data? Do you have a partner that can help you look at the data? And what does it mean? Meaning maybe what seems like good is actually a little bit unfavorable and perhaps could actually be a lot stronger with a partner, right? What's good, better, great, and all that, and the level of disruption that it might require. What I would say is in most instances in this space, if you reach out, whether it's someone like Clearway or others, you can get a sense of what that potential looks like before you decide build, buy, or partner. And having that information available to you helps you make the most educated decision on what path is best for you. But I think that would be the way that you'd really focus on growing. It has to be a very intentional effort with the right amount of data and guidance to get it started.
Nicole, thank you. Beth and Laurice, thank you for thoughts. And this brings us to a really good spot to share some of these resources. Nicole, you said, be intentional, have the data, know what you need to make the right decision as you're looking for these opportunities to overcome these obstacles in this landscape. And so would like for the panel to talk for just a minute about what resources you leverage and would recommend for hospitals and health systems. Beth, let's start with you.
Thanks, Allison. So you set me up for a shameless plug for hospital associations. But seriously, this is why we are here. Our job is to serve you. So please never hesitate to reach out to your hospital associations at the national, state, or regional level. There is, nothing that our staff likes more than to hear directly from our members, because you are all the reason why we do what we do. So, please look to us as one of your go-tos for support.
Thank you, Beth, and the America's Essential Hospitals team on that. Nicole, let's come to you next and talk about especially your position in leading development of these strategic partnerships as resources. Talk to us a little bit about what some of your recommendations would be.
I would recommend, much like our panel here is pretty diverse. We've got policy, we have legal, we've got operations and partner vendors. I think really looking internally first at some of the resources you have, how established is the pharmacy program, your data support for pharmacy, physician champions, and then inadvertently where there absolutely are some gaps, looking externally for one or multiple partners to look at, how do you really develop this program? At Clearway, while we have a lot of all the necessary in-house expertise to develop this program, we do rely also on others because, like America's Essential Hospitals or Laurice and her team related to legal strategies, when we go and talk to each hospital or health system, their needs, their landscape, and their community are all very different. And understanding how to best support a system looking to grow something like a specialty pharmacy, it's important that you really have a view of the entire landscape to develop that program. So I would recommend, regardless of the ultimate decision, that you leverage an external resource to help set the tone for what is possible within the system and then take action from there.
Good. And Laurice, certainly want to come to you as we look to the legal and advisory service that you bring. So would love to hear your perspective on resources for this group too.
Thank you. I appreciate that. I think the key themes from today are that technology is moving faster than we can keep up. Healthcare continues to evolve. Partnerships, alignments, whatever they look like for you, are an opportunity to move forward and allow you to keep pace with innovation. I love working with teams such as Clearway because I get to be a strategic thought partner on the front end. So I would just encourage everybody to find their strategic legal thought partner and bring them in early You can often save yourself a lot of time, money, and heartache if you bring in your kind of legal strategic advisor on the front end. There are a lot of ways to get to yes. The rules are complicated. Sometimes there's a bright line, but oftentimes there's not. And so the right legal partner can really help you move things forward. So it has been a pleasure being here today, and I appreciate this discussion.
Thank you. And I can't think of a better way to end a conversation about all of these topics, ending with resources, than to thank our partners through this process. And so on behalf of Clearway Health, we are grateful. Laurice, to you and to the Health Law Strategist team, and Beth, to you and America's Essential Hospitals. Beckers, thank you for the opportunity to be here. And to everyone, thank you so much for joining. With that, Mariah, I will pass it back over to you. Thank you.
Wonderful. Like she said, that is all the time we have for today. I want to thank all of our presenters for an excellent presentation, and Clearway Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you again for joining us, and we hope you have a wonderful afternoon.